So today I'm going to talk about a couple of our studies that use mathematical models to understand the transmission dynamics of SARS-CoV-2. The disease transmission is a typical complex dynamical system, and it involves complex interactions among pathogen, host, and the environment at different scales. At the population level, disease transmission has the defining characteristics of a complex system. First, disease transmission is highly stochastic, particularly during the early phase of its establishment in human population. And this high stochasticity is usually manifested by individual heterogeneity and superspreading events. And also, disease transmission is dynamic. The COVID-19 pandemic in the US has multiple waves driven by the interactions and the feedbacks between disease dynamics and also human behavior. And lastly, disease transmission is very nonlinear. So we know the initial growth of an epidemic is exponential, and the interventions on disease transmission usually have a nonlinear effect. And the long-term dynamics of some childhood diseases like measles is even chaotic. So despite the complexity of disease system, it is poorly observed in our real-world system. As indicated by this surveillance pyramid shown here, the cases observed in our surveillance system is only the tip of the iceberg. This is particularly true for an emerging infectious disease like COVID-19. And our routine surveillance system is passive and is subject to selection bias and random noise. So all these limitations make it difficult to understand disease transmission using surveillance data only. And more recently, other data sources are becoming increasingly available, and those data sets include mobile phone data to track people's movement, serological surveys that look at antibody levels among population, and also like search query signals like Google Trends and other social media data and sequencing data with lower cost. These data sets usually are of different types and at different scales, so they all contain information on different aspects of the disease transmission, but it is hard to synthesize those data sets together in a coherent way. And this situation is analogous to the story of black man and the elephant. So every person can have a partial observation of the animal, but how should we piece together those observations to get an overview of the animal? So in our approach, we use mathematical models to serve as the skeleton of the animal. So more specifically, we use our current best understanding of the disease system to build the model and synthesize various observations into the model. So this model inference system can answer questions that are otherwise difficult to answer using single data stream. And today I'm going to talk about two case studies on SARS-CoV-2 in China and in the US. So in the first study, we will talk about undetected infections in China. So back in January 2020, we heard about epidemic outbreak in China. And this map shows the cumulative number of reported cases in 375 cities as of January 23rd. So there were only about 900 cases reported, but we observed a really fast spatial spread across the country. For endemic coronavirus that causes common cold, we know a lot of infections, they have no symptoms or only with mild symptoms. So this motivated us to answer two questions. So how many infections were not detected for this new virus, and how infectious are the undetected infections? I mean, those questions are very important because it is related to our ability to contain the outbreak and also the potential for a pandemic. And unfortunately, these questions are difficult to answer using just single surveillance data. This outbreak occurred during a very special time period in China, Chunyun, which is defined as the travel during Lunar New Year in China. So in 2018, there were about 3 billion trips happened in just 40 days. So it's a massive population migration across the country. and which can greatly facilitate the transmission of disease, right? So we use constant location-based surveys to keep track of people's movement across different cities during the period. And we modeled disease spread across between 375 cities in China during the period from January 10th to January 23rd, before Wuhan lockdown. And we used a metapopulation model to simulate the spatial dispersion of the disease within China. So here are the details of this model. So the total population are divided into several categories or compartments: susceptible, exposed, documented infection, undocumented infection, and removed. The transition between different categories or compartments is described by a set of differential equations shown here. The terms in the left box represent within city transmission, and the terms in the right box shows the cross-city migration. And in this model, we introduced several parameters for all the cities to keep the model parsimonious. And those parameters include the transmission rate of documented cases, the relative transmission rate of undocumented cases, latency period, infected period, reporter rate, and mobility factor to adjust across city mobility. And some of the key parameters, like the basic reproduction number, can be estimated using those parameters. We are particularly interested in two parameters: the fraction of undocumented infection and the relative contagiousness of those infections. We calibrate the model to surveillance data of daily new cases in each city, and we use the Bayesian inference techniques, the iterative filtering with the ensemble adjustment Kalman filter. So this method has been widely used in numerical weather prediction and is applicable to like high-dimensional systems we developed here. So in this model inference system, we use data assimilation to combine model and data together and to estimate model parameters. And before we apply this inference system to real-world data, we want to know whether those parameters can be identified by the inference system. So we performed a test using synthetic model-generated outbreak. So what we did is we generated an outbreak using known parameters, and we generated observations and fit the observations back into the model inference system. And we want to see whether those parameters can be recovered by the inference system. The figure on the right side shows one example of this experiment. So the red vertical line shows actual parameters we use to generate the synthetic outbreak. And the blue bars represent the distribution of the estimated parameters. Now we can see all the parameters can be distantly estimated. And we performed several these tests using different combinations of parameters. And we want to make sure the system can work for a variety of outbreak situations. So we then apply the inference system to the real world data, and the parameters we estimated are shown in this table. So most importantly, we estimate that about 86% of infections were undocumented before travel restrictions. And the transmission rate of undocumented infections was about half of documented infections. So they are less contagious than observed infections. And this figure shows the comparison between the real world observations, the red crosses, and the model simulation we run using the estimated parameters represented by these blue boxes. And we first want to understand the role of undocumented infections in driving the spatial spread of COVID-19 in China. So we run a counterfactual simulation, assuming that those undocumented infections were not contagious. And in this figure, we compared the model simulation using the estimated parameter represented by these red boxes, and also the counterfactual simulation assuming the undocumented infections were not contagious. And by comparing those two set of simulations, we found that undocumented infections are the source of about 79% of documented infections. So you can see, even though they are less contagious, the undocumented infections actually drive the disease outbreak in China because of they have larger number. And those findings were later confirmed by other empirical studies. So this shows undocumented infections plays a central role in driving the transmission dynamics of SARS-CoV-2, and it will be very difficult to contain the outbreak. So in the second study, we want to estimate the burden and the characteristics of COVID-19 in the US during 2020. And here we focus our study in 2020 before the massive rollout of vaccination in the US. So in this study, we want to ask three important questions. How many people were infected in the US by the year end of 2020? And what's the community infectious rate, which is defined as percentage of contagious population in a community at a given time? And also how CFR, case fatality rate, and IFR, infection fatality rate, changed over time. To answer those questions, we developed a metapopulation model to simulate the COVID-19 spread across US counties. And in this model, we consider two types of mobility, the regular work commuting and the random movement of people. So the total population is divided into subpopulations based on their work and based on their home and work locations. For commuters, they travel regularly between their home and the work locations. And this information can be obtained from census surveys. And for random visitors, they travel across different locations in a diffused way, like a Markov process. And this model structure has been previously used to simulate and predict the spatial spread of influenza in the United States. And so we developed a metapopulation SEIR model for over 3,000 US counties. We got the inter-county commuting data from the US Census Bureau, and this map shows the intensity of inter-county commuting across different counties. So we can see there are some strong connections between certain metropolitan areas. But this data is static over time. But we know back in 2020, many people work from home, and their mobility behavior changed dramatically during the pandemic. So we need to adjust for this variation of mobility pattern. So we used mobile phone data from the SIF graph to adjust the spatial and temporal variations of the inter-county mobility in the model. And to also reflect the different intervention measures in different counties, we allow each county to have separate transmission rate in this model. This model has been previously used to generate initial simulations of COVID-19 spread in the US at the county level under different control scenarios, and also to estimate the impact of earlier intervention of COVID-19 in the US. So again, we use the common filter to calibrate the model to surveillance data of county level daily case data. Here, the figure shows the model calibration at the US national level and 5 major metropolitan areas, New York, Chicago, Los Angeles, Phoenix, and Miami. Here, we only show the results from several metropolitan areas, but the fitting was performed for every county in the US. So in addition to the model calibration against case data, we also performed out of sample validation using seroprevalence survey data in the US. The CDC gathered data on seroprevalence in 10 site surveillance from March to August 2020, and also state level seroprevalence surveys after August. However, we cannot use the directly observed seroprevalence to validate this model because we know antibody wins in population, right? So especially among patients with no symptoms and mild symptoms. So before we do the validation, we need to adjust for this antibody waning or several reversion in the data. So we adapt a method that was previously used to adjust antibody waning in Manaus, Brazil, to adjust this antibody waning in the US data. And in this figure on the right side, we compare the directly observed seroprevalence data, the black dots here, with the adjusted seroprevalence data shown by the red dots here. And in this figure, the x-axis shows the adjusted seroprevalence, and the y-axis shows inferred infected population using the model. And the color shows indicates the date of sample collection. So we can see the model inference can decently capture and match with the adjusted seroprevalence data in the US. So with this model calibration, we first look at the ascertainment rate, the fraction of infection that were captured by the surveillance system. So nationally in the US during 2020, the overall ascertainment rate was estimated to be 21.6%. That means only 1 in 4.6 infections were reported in the US. The ascertainment rate increased from about 10% in March to about 25% in December. So you can see the reported rate has more than doubled during the year, but still the majority of infections were not reported. We also observed a substantial spatial variations across different locations. For instance, here we can see Phoenix and Miami typically has a higher reporting rate than the other metropolitan areas and also the national average. And then we look at the susceptibility in different locations. Nationally, by the year end, the susceptibility dropped to 69%. So that means about 31% of US population has been infected during the year. And we also observed remarkable spatial variation across different locations. And those two maps shows the county level, the percentage of susceptible population on August 1st, 2020 and December 31st, 2020. So by the year end, we can see New England area has the highest susceptibility, which means the smallest number of infections. But in some counties in Midwest, like some counties in Dakotas, the susceptibility has dropped to below 40%. And those are also the areas that were hit hard during the fall and winter wave. We further look at the community infectious prevalence, which is the percentage of infectious population in a community at a given time. And this figure shows the result at the national level and in 5 major metropolitan areas we looked at. The blue line shows the daily confirmed cases, and the red line shows this community infectious prevalence. So in the US at the national level, the community infectious prevalence rose up to about 1% during the fall winter wave. So that means about 1 in 100 people in the community were contagious during this time. But for some metropolitan areas like Los Angeles, we know there was a huge outbreak during the winter. The community infectious prevalence rose up to 2.5%, which is very high. And that means one person in every 40 people in the community were contagious. So, the chance of getting infected under this community infectious prevalence is very high. We also combine the data, the surveillance data on death, and also line list data released by the CDC to compute the case fatality rate and the infection fatality rate. And in this analysis, we also consider the time lag between between case confirmation and death, informed by the line list data. And here I show the instantaneous CFR and IFR during a certain period of time. The blue line shows the CFR, and the red line shows the IFR. So in the US, nationally, both CFR and IFR dropped over the year. The IFR dropped from about 0.8% in April to about 0.3% in December. So this drop may be caused by a number of factors. For instance, the change of age profiles in the infections. We know there are less and less older people get infected during this time, and also probably because of the awareness of disease, early detection of disease, and also improvement of therapeutic treatment, like the dexamethasone and other steroid medicine. But we also noticed that during the year end, when there are large outbreaks in the fall-winter wave, in certain locations like Los Angeles and Phoenix and Miami, we saw there's a rise of IFR, infection fatality rate, during this time period because the healthcare system was stressed because of a large number of people hospitalized in hospital. So this shows that the IFR or CFR is actually a time varying parameter of property that's driven by a number of factors. And lastly, we look at the cumulative IFR since the beginning of the pandemic. At the national level, the cumulative IFR dropped from 1% in the spring to about 0.4% in December, in the winter. But we want to note that in our analysis, we didn't consider underreporting of death in surveillance data. So this estimation could be biased low, but even with that, the infection fatality rate of COVID-19 is much higher than seasonal flu, so it is still very dangerous. And vaccination can really help to reduce the mortality rate of the disease. So to sum up, I just introduced the two studies that use mathematical models to combine multiple types of observation to answer some questions regarding the transmission dynamics of SARS-CoV-2. In the China study, we used a metapopulation model to combine case data and the mobile phone data to study the impact, the role of undocumented infections. In the US data, we used a metapopulation model to combine case data in the surveillance, commuting data from census survey, mobile phone data to keep track of people's movement, and seroprevalence data that shows the antibody levels in populations, and also line list data by the CDC and death data in the surveillance. So in our new study on antimicrobial resistant pathogens, we also developed a detailed agent-based model informed by hospitalization record and also sparse diagnostic data on MRSA, methicillin-resistant Staph aureus, to better identify asymptomatic spreaders of AMR pathogens in hospital settings. I mean, all those studies show the potential of using mathematical models to synthesize different data streams into the model to answer some questions that are difficult to answer using single data streams. And lastly, I would like to thank my collaborators in those studies, particularly Jeff Shimon from our department, and also funding support from several funding agencies. Thank you so much, and I can take some questions.
Sen, thank you so much. That's great. Those models are amazingly accurate, it seems. The data fit, the predictions incredibly well across all those curves. Astounding. So I had one question. So am I reading it right that your data are saying that roughly there's about maybe five times as many undocumented as documented on average across the board?
Yes. This is the main result of the US study. So they're about 4.6 times of the reported, almost 5 times. Yeah.
Right. So that's kind of huge. I mean, that's kind of an important number. So it means when we're given some number for the number that are known, infected, or documented, we should multiply by 4.5, and that means we're getting to very high numbers, I guess, that are infected, mild cases, not aware of it.
Yeah, but I want to see that this ratio changed over time. Like at the beginning, a lot of studies indicate that, independent studies indicate that maybe the number of infection in the spring was like 10 times higher than the reported number because of lack of testing. But this detection rate certainly increased over time because of expansion of testing capacity. But still, I think there's still some barriers for getting tested. Some people, they have completely no symptoms. They won't go to the hospital to get tested, right? So
sure. Yeah, and I guess the remaining issue is then how well protected are those huge numbers that were exposed, infected, but no symptoms? How? Yeah.
Yeah.
Interesting.